It's really a great honor to be here for Mapicon 2018. A great job has been done by the organizing committee headed by Dr. Vitul Gupta in arranging such a mega academic event. It's really appreciable. Dyslipidemia, the Indian perspective. Why are we discussing this today? Because this is a hot topic. Why is it a hot topic? We as physicians, we have a good chunk of patients where we as physicians are really bothered about their abnormal lipids. Because we want to treat it, they are creating problems. And then we have good chunk of patients who are bothering us as physicians. They are bothering us with their lipids. You ask them, what is their problem? The patient enters your chamber. You ask the patient, what is the chief complaint? The patient shows his or her mobile set, and that carries a report of lipid profile. That is his chief complaint. He says, मेरा cholesterol बढ़ा हुआ है. Doctor साहब, ये मेरी chief complaint है. इसको treat करो. So, this is a hot topic. We need to know when to treat, why to treat. We always take lipids as our enemies, but this is wrong. They are not enemies, always. So, we have so many good advantages of lipids. They help in cell differentiation and growth. They help in energy production, and more important than that, energy storage. There are stores for energy. They are insulators, body insulators. And they help in hormone production, digestion, absorption. So many good points. This is just in brief. We talk of lipoproteins. What is a lipoprotein? You know, lipids, they are not soluble in water. So they cannot circulate in blood. They cannot. They need some help. So the lipids have to take the help of proteins to circulate. And this combination is called lipoprotein. Now this slide is very important. Why? Because we have different type of lipoproteins. High density lipoproteins, low density lipoproteins, very low density lipoproteins. And in fact, we have another class which is in fact very important for our Indian population, which we're going to study. That is intermediate density lipoproteins. Right? Now, what stands out in this slide is this green color. That is the high density lipoproteins, because this is one which is helpful to the body. It is anti-inflammatory, whereas rest all of them, LDL, VLDL, IDL, they are pro-inflammatory, they are pro-atherogenic, they are promoting atherosclerosis, whereas the HDL is anti-atherogenic. It removes the cholesterol from the circulation and puts it somewhere else in the body, maybe in the liver or somewhere, so that it doesn't harm us. Whereas rest all of them, they are taking out the lipid from the liver and putting it into circulation. So this is a broad classification of these lipoproteins, and cholesterol is same. What makes the difference is ये कोलेस्ट्रॉल कौन लेके जा रहा है, कौन सा लाइपोप्रोटीन वो कोलेस्ट्रॉल लेके जा रहा है, वो फर्क डाल रहा है. कोलेस्ट्रॉल इज सेम. नाउ दिस इज एपोलाइपोप्रोटीन. व्हाट इज एपोलाइपोप्रोटीन? जो लाइपोप्रोटीन का प्रोटीन वाला पार्ट है, दैट इज कॉल्ड एपोलाइपोप्रोटीन, नथिंग एल्स. सो इफ वी टॉक ऑफ एपोलाइपोप्रोटीन्स, वी हैव ईदर एपो बी और एपो ए. Now again, just like the green in the previous slide, here ApoA1 stands distinct. Why? Because this is the one which is carrying HDL. And ApoB100, this is ApoB48. ApoB48 is carrying chylomicrons, ApoB100 is carrying VLDL, IDL, LDL and lipoprotein A, which are again all atherogenic. So again, what stands out distinctly in this slide is apolipoprotein A1, which carries HDL and which is protective for the body. This is just to tell you, you are all aware of it. This is the adult treatment panel, ATP3 classification of the normal levels of lipid, and what we should remember is that LDL should be less than 100, total cholesterol should be less than 200, and HDL, the good one, good cholesterol should be more than 40. What is dyslipidemia? It is a disorder of lipoprotein metabolism that causes what? It causes abnormal amount of lipid in the body. Now, abnormal amount can be hypo, can be hyper. Lipids कम भी हो सकते हैं body में, lipids ज़्यादा भी हो सकते हैं. लेकिन hypolipidemia is not given that much importance because hypolipidemia is not giving us direct symptoms. It is not giving us direct disease. It is a part of some nutritional problems, maybe metabolic problems, genetic problems. Whereas hyperlipidemia is directly giving us disease. चाहे वो हार्ट अटैक कर रहा है, चाहे वो स्ट्रोक कर रहा है, चाहे पेरिफेरल वैस्कुलर डिजीज कर रहा है, वो हमें डायरेक्टली डिजीज दे रहा है तो हम उसको इंपॉर्टेंस दे रहे हैं. सो फॉर ऑल प्रैक्टिकल पर्पसेस dyslipidemia is taken as hyperlipidemia. So whenever we talk of dyslipidemia, we talk of hypercholesterol, hypertriglyceride, hyper LDL and low HDL. These are the four important components of dyslipidemia: low HDL, high triglyceride, high LDL and these cholesterols, total cholesterol. So why do we have dyslipidemia? It is a mixture of genetic problems, dietary problems, physiological factors. And very briefly, we'll touch them, but we will touch them keeping in view our Indian population. We are not concerned about the Western population because we are going to treat Indians. Now, dyslipidemia is of two types: primary dyslipidemia and secondary dyslipidemia. Primary dyslipidemia means जिसका कोई cause नहीं है, primary है, essential है, तो generally it is genetic. It is because of genetic mutations. But as clinicians, what we should remember is कि कौन से patients हैं जिनमें हमें primary dyslipidemia suspect करना चाहिए. ये चार conditions हैं जहां हमें primary dyslipidemia suspect करते हैं: premature heart disease, family history of atherosclerosis, a serum cholesterol of more than 240 milligrams per deciliter, and if the patient has physical signs of hyperlipidemia, xanthomas है, lipemia retinalis है, eye में signs हैं, वहां पे हम primary dyslipidemia suspect करते हैं. Otherwise, majority of the adults we come across, they have secondary dyslipidemia. And why do we have secondary dyslipidemia? Unlike primary dyslipidemia, here the main cause is lifestyle, sedentary lifestyle. Dietary habits are faulty. We are taking more of saturated fats. We are consuming trans fats. Now the focus is going to trans fats. Any oil which is being used again and again, which is being consumed for more than, being used for more than 6 hours, is a trans fat. And that is what is happening in our bakery products, in our snacks in the form of samosas. The same oil is being used day and night, one fry after the second fry. That is creating trans fats, which are highly atherogenic. And then some drugs are also increasing cholesterols, maybe in the form of beta blockers, thiazide diuretics, some drugs which are used for treating HIV, and some hormones. Just briefly, the global prevalence of dyslipidemia. So much importance this disease has that it is causing 4.5% of the deaths globally. And now, what is highlighting in this slide is, just look here, in a developed country like United States, less than 50% of patients with high LDL cholesterol, they are getting treatment. Less than 50% are getting treatment. And more important than that is, of those who are receiving treatment, less than 35% are achieving the target goal. जो हमें lipid के treatment से goal achieve करना चाहिए, less than 35% of them are achieving that. So this is the situation in a country like developed country. Now let's talk of India. What is the prevalence? A study has highlighted that the cholesterol is high in 25 to 30% of urban population of our country and 15 to 20% of rural population. Quite high figures are there. State-wise, what is the mean cholesterol level state-wise in our country? We are happy to see Punjab, it is just 169 milligrams per deciliter, and I want this news not to cross this hall because Punjabis are always ready with desi ghees. So let this news remain within this hall. And let's see Kerala. Kerala has a mean cholesterol of 197 milligrams per deciliter, which is very high. Now, can anyone guess in the audience why the Keralites have a high mean cholesterol value? The one reason is because of high consumption of coconut oil. And the second is they are too much dependent on non-vegetarian food in the form of beef. Now, the peculiarities among Indians, this is our topic, this is the highlight. So we will see what are the peculiarities and why we are different than the Western world. Dyslipidemia, you know, is directly involved in causing cardiovascular diseases. Most important cause. And around 32 million people in our country, they are suffering from coronary artery disease. And the coronary artery disease in India, you know, is different. Early age, diffuse disease, and less, around 10% of heart attacks, they are occurring in less than 40 years of age. And dyslipidemia is the main factor which is causing cardiovascular disease. So, dyslipidemia, association with cardiovascular disease is different among Indians. And this is the average, now 20 to 35% of population is having high cholesterol level. This is what is important. So, our population is developing coronary artery disease at a younger age. Now, what is more important? आप एक इंडियन का लिपिड प्रोफाइल करवाओ और उसको वेस्टर्न के साथ कंपेयर करो. हो सकता है हमारा टोटल कोलेस्ट्रॉल नॉर्मल आए, हमारा एलडीएल कोलेस्ट्रॉल हो सकता है नॉर्मल होगा या थोड़ा सा ज्यादा होगा. तो हम सोचते हैं कि हमारा लिपिड प्रोफाइल तो नॉर्मल है. कोलेस्ट्रॉल टोटल इज नॉर्मल, एलडीएल कोलेस्ट्रॉल इज नॉर्मल, वेयर एज वेस्टर्न पर्सन का एलडीएल वुड बी हाई, टोटल कोलेस्ट्रॉल वुड बी हाई. बट वी आर मोर एट रिस्क. वाई? बिकॉज वॉट वी हैव इज हिडन. वो हिडन क्या है? हमारा ये एक नई चीज है जो हमारे ब्लड में ज्यादा है. दैट इज कॉल्ड स्मॉल डेंस एलडीएल. दिस स्मॉल डेंस एलडीएल इज द वन विच इज क्रिएटिंग प्रॉब्लम. एलडीएल नॉर्मल या स्लाइटली ज्यादा है, लेकिन स्मॉल डेंस low density lipoprotein cholesterol is the one which is creating problems, and the triglycerides are also high, and of course the HDL is also low. And this combination, this triad of a high small dense LDL, high triglyceride and a low HDL is called atherogenic dyslipidemia. This is the highlight of Indian population. And in addition to that, of course, we have lipoprotein A. It is again an atherogenic protein. Our population also has a higher value as compared to the Western world. Now, this is just to show the mean triglyceride value. We have compared the mean triglyceride value of an Indian with a Caucasian, and you see the mean triglyceride value we have is around 150, more than that. and whereas a Caucasian has it around 125 within the normal limits. So हमारे triglycerides level ज़्यादा हैं. HDL. HDL हमारा लो है. हमारा HDL fall कर रहा है almost around 45, 46 border, whereas a Caucasian has it around 52, which is a good cholesterol. Protective H जो है, वो हमारा कम है. So, we have, this study was done by ICMR, very significant study this was. This showed that the Indians have atherogenic dyslipidemia consisting of low HDL, high triglyceride, and high small dense LDL, small dense lipoprotein. What is more different? In addition to dyslipidemia, conditions like metabolic syndrome, diabetes, obesity, they are also causing cardiovascular disease in association with dyslipidemia. These conditions, they are also different in Indians. So once the diabetic pattern is different, obesity is different, metabolic syndrome is there, this in combination with dyslipidemia is giving a different pattern. And when we treat dyslipidemia, we have to remember this important point, which is again a peculiarity of Indians, that is the pharmacokinetics of the drugs which we are using. It is different in Indians. We cannot use the same dose what we use in a Western person. We have to use smaller dose. We are slow metabolizers. This we are going to come when we discuss the treatment part. This is diabetics. Diabetics, dyslipidemia. A very dangerous combination. But such a high prevalence of dyslipidemia is seen in Indian diabetics. We, right now, there was a figure just 2 days back that right now we have around 69 million diabetics in our country. And see, 85% of male diabetics and 97% of female diabetics, they are dyslipidemic. So that means practically 9 out of 10, every diabetic has dyslipidemia in our country. And this is the same triad of dyslipidemia which is existing in the Indian diabetic, that is increased small dense LDL, high triglyceride, and a low HDL cholesterol. Now these are the peculiarities in Indians. Now let's see why so. No ma'am, I'll take a little more time. 2 minutes. No, but ma'am, I need 40 minutes. It's just been 12 minutes I've been on my talk. Please. I was allotted 40 minutes. Okay. So, if we look at this figure, the person sitting on the right side is an Indian and the person sitting on the left side is a Caucasian. They have the same BMI, but the Indian is having more fat at the same level of body mass index. The Indian is having a higher fat because of increased visceral fat, and he is more prone to the problems associated with dyslipidemia, although the personality looks same. Now this is a point where most of patients, they contest with us. You tell them that you are obese, your patient will tell you कि जी मेरी बाजू तो ठीक है, मेरी legs तो बिल्कुल ठीक है, मेरे तो यहाँ ही थोड़ी problem है. So then you have to convince that patient कि यही problem है, सारी problem ही यही है. So this is the comparison of a person, a Caucasian, and this is a typical Indian. Typical Indian. This is the abdominal obesity, visceral obesity, which is harboring most of our fats. And this is the microscopic level where we see the cellular difference. This is the Asian adipocyte, very large size cell, which is harboring more fat, and this is the wide population. So, at the same level of BMI, the body fat of an Indian is higher as compared to the Caucasian. So what we have is subcutaneous abdominal adipose tissue and the intra-abdominal adipose tissue. They are much more in an Indian as compared to a Caucasian. Remember this. And just look at the last point, which is very important here. This subcutaneous abdominal tissue is associated with hyperinsulinemia. Hyperinsulinemia. And this is happening in our children and adolescents, and which is very important because childhood obesity takes you to adult obesity. Not only that, we have fat deposited at ectopic sites. We have fat deposited in the liver, muscle, heart. There is a role of genetics in our population. There are some genetic mutations, polymorphisms, which are taking us towards dyslipidemia. One of them is Apolipoprotein B polymorphism. Another is APOC3 polymorphism. Then we have MCP1 gene polymorphism. Very important, and this is creating insulin resistance and abnormal lipid profile in North Indian population. This is what is important for our population of Punjab. There is some genetic problem in the population of Punjab, and that is CRP gene polymorphism. Now this is a very interesting theory, starvation gene theory, right? They say that we were exposed to drought for long times, so our genes adapted in a way to store fat. So we are adapted कि हम जब हमारे पास abundance है, we store the fat, and when we are in crisis we can use that. But with the grace of God, now we don't have crisis, so we are in habit of storing that. So dyslipidemia in Indians is a combination of abnormal diet, abnormal physical activity, and genetic factors. So if we have everything different than our Western population, we have different diabetic, different coronary heart disease, different body composition, different fat composition, then our treatment guidelines should also be different as compared to the Western world. These are the various lipid-lowering drugs. You must have heard about all of them, and the outstanding among them, you know, is statins. It's everywhere statins, statins, statins. And we have different statins: atorvastatin, fluvastatin, lovastatin, pravastatin. Then we have fibrates. Then we have PPAR, alpha and gamma agonists. This is a newer drug, seroglitazar, which is used for diabetic dyslipidemia. Then we have azitimib, which is a cholesterol absorption kam karti hai ye intestine mein. Niacin hai. These are the various drugs. Now, this was the guideline which was given by the ACC-AHA in 2013 regarding the lipid management. This was for general, not for Indians. But what is our relevance is that Asians, they respond more strongly to statins because we have lower BMI and we are slow metabolizers of statins. So we should be using low dose, and moderate dose should be started, and slowly the dose should be titrated, taking care of the side effects. Regarding non-statins, there were two good studies, the field study and the accord study, which highlighted the use of fibrates, especially where the triglycerides levels are high. This is the guidelines given by the American Association of Clinical Endocrinologists in 2017, which says that the LDL should be less than 100 and the triglycerides should be kept less than 150 milligrams per deciliter. And in brief, I'll tell you about these 2017 guidelines because basically we'll go to the Indian guidelines. This is just to tell you how we can compare these. So this guideline came out with risk stratification. इसने 5 risk groups बनाए हैं: low risk, moderate risk, high risk, very high risk, and extreme risk. So the basic point to show you in this slide is that they have kept that ideally the LDL in high risk should be kept less than 55. अब मैं आपको अपनी guidelines बताऊंगा Indians की, वहां पे ये target, हमारी guidelines, they are more strict. We have kept it as 50, not 55, 50. Now, these are the various statins required to achieve 50% LDL reduction: rosuvastatin, atorvastatin, simvastatin. Recently, there was a study by our very respected professor, Dr. G.S. Wander. He did a study on the physician's approach to the various statins, and he concluded that atorvastatin is the commonest being used, and ezetimibe is being added as on the atorvastatin, and in acute coronary syndrome, high dose of atorvastatin is being used. But I think we should use statins keeping in view the patient's pocket, right? Because the top three ones, they are good enough. Regarding combination therapy, statins, if are not being tolerated or not able to achieve the targets, then only we should add other drugs like fibrates, niacin, and all these. Fibrates are basically used for hypertriglyceridemia. Bile acid sequestrants not used because they are not good, they are raising the triglyceride levels. Yes, this is a good drug, ezetimibe. It decreases the absorption of cholesterol in the intestinal tract, and it can be added to the statins. These are some of the newer therapies which are practically not used. Omega-3 fish oil, very good to use, decrease the triglyceride levels. Niacin, again used to decrease the triglyceride level, and it can be added with a statin. Now, this is important for us. I would just require 2 minutes to tell you that this is the guidelines for Indians which came out in 2016. It is the Lipid Association of India expert consensus which was published in JAPI, and it has made out 4 risk categories: low risk, moderate risk, high risk, and very high risk, depending upon the conventional risk factors and non-conventional risk factors. Conventional risk factors like coronary artery disease, diabetes, chronic kidney disease, familial hypercholesterolemia, metabolic syndrome, and non-conventional like coronary calcium scoring, intima media thickness, and these were some of the non-conventional. Accordingly, we have grouped them into 4. Now, this risk stratification is very important once you want to treat dyslipidemia. Now, just highlighting points. Number 1, LDL cholesterol. It is the primary target for therapy, and we should reduce it, and this reduction of LDL lowers the cardiovascular risk. Second is non-HDL cholesterol. This is very, very important. Total cholesterol minus HDL cholesterol is non-HDL cholesterol. And why this is important for Indians? Because as I previously mentioned, our LDL cholesterol might be normal, but what is abnormal is small dense LDL, IDL, and triglyceride, which is going to be measured by non-HDL. And you need not take a fasting sample for non-HDL, because total cholesterol and HDL cholesterol, they are not acutely affected by meals. So आप non-fasting भी कराओगे कोई फर्क नहीं पड़ेगा. Total cholesterol minus HDL is non-HDL. For Indians, non-HDL is a co-primary target, and again statins are the primary drugs to control non-HDL. High triglycerides, they are very common in Indians, and again statins are the drug of choice, but you can add a drug like fibrate if the statins are unable to do so. HDL cholesterol, again very important independent risk factors, and again statin is the mainstay of treatment. So statins are the mainstay of treatment. Type of statin used should not matter. It should be pocket friendly, and this is to highlight that this is our association. Indian association says very high risk group keep LDL less than 50, high risk keep it 70, less than 70, in moderate and low risk keep it less than 100. And what about non-HDL? आप देखो, non-HDL should be kept within 30 milligram deciliter of LDL. That's all. This is the first column tells you this is what is important in our diet. Raw, cooked vegetables. We should use grilling and boiling instead of frying. We should prefer whole grains. So first column is the preferred one, and the last column should be chosen not even as the last modality. So what is the Indian paradox? We have high disease burden, we have a different lipid pattern, we have a disease occurring at early age, and we have more severe form of disease with a very poor outcome. This is what stands out in our population. So, dear colleagues, the take-home message is that we are prone to that triad of atherogenic dyslipidemia. The cardiovascular disease in our population occurs at a younger age. It is a diffuse disease and difficult to treat disease. We have a different cardiovascular risk factors in addition to dyslipidemia. Our more focus should be on risk stratification, as our guideline says. We should correct our faulty dietary habits. We should correct alcohol abuse. The physical activity should be increased so that at least we exercise for 150 minutes in a week. We should more go in for routine health checkups, which are still lacking as compared to the developed world. The statin dose should be different for Indians. We should be for low or moderate dose because of low BMI, and we are slow statin metabolizers. But still, statins are the gold standard for treatment. And the statins and non-statins should be used only if the statins are intolerable or they are giving side effects, and side effects of statins like muscle problems, myositis, and new onset diabetes. They are some of the important side effects which should be taken care of. And non-HDL cholesterol is a new concept, important concept, and a novel concept. So, future research still needs to be done on so many issues regarding Indian dyslipidemia. Thank you so much for your patient hearing. And it's really an honor for me here today because I have one of my most respected teachers here, Professor G.S. Wander. And I am very proud to say that I am his student. And I am very lucky to be his student.